Today we are going to have two talks. The second one probably is one that I would be more interested in as a clinician to listen to when Dr. Unni speaks on antibodies in thyroid. Now, I'm supposed to talk to you on advances in thyroid and a lot of it is going to actually center around some of the work that we have been doing at our own institute. And based on one of our publications in the Journal of Clinical Endocrinology and Metabolism that's come out in the May issue of JCAM. It's actually the lead article of JCM May 2021, along with a commentary from Professor Eric Alexander. But before we go into that, just a very quick recap. In India, it is thought that the prevalence of thyroid nodules is somewhere around 12%, though we might argue about the prevalence data depending upon the study, whether it's upon clinician, primary care physician, or is it an endocrinologist? And the other bit of the data, which again is a bit dodgy, is the thyroid cancer prevalence that we have is about somewhere around 8.7 per 1 lakh per person years. And it's the commonest endocrine cancer. And like every other country on earth, thyroid nodules and thyroid cancer prevalence is on the rise in India, predominantly because of greater imaging modalities being used. And again, there is a 1 in 20 significant nodules are malignant with a female preponderance. And it's the 6th commonest cancer in women, accounting for 4% of all cancers. Now, this is a very rough classification of thyroid tumors, and I'm not going to talk about all of that, but just going to talk about the one circled in red, because that's where about 93-94% of all our thyroid tumors fall, that is differentiated thyroid cancers. So we are going to just talk about differentiated thyroid cancers and what biomarkers we could possibly be using. Now, this is again something that every endocrinologist or clinician already talks about, that, if you have a thyroid problem in form of a nodule, there has to be some kind of a background genetic susceptibility, and then perhaps someone has a benign nodule or a malignant nodule. Now, one of the things, unlike which we appreciated in the past, we now know that this driver mutation that causes thyroid cancer and leads to thyroid cancer is not a single step process, and it's probably a multi-step process. And that's important because of all of the intermediate entities like NIFT-P and things like that we are talking about. They might very well be somewhere in between benign and malignant. And what we as clinicians do when we find someone presenting with a nodule, we ask for a thyroid function test, then we go for a thyroid ultrasound, and then if required, we go for an FNA. Now, this is the thyroid ultrasound criteria or gradation we usually tend to use. That's the ACR thyroid score. Now, a lot of people put too much of emphasis on the ACR thyroid score. And what we have found out from our own study as well, that use the thyroid only to decide whether you're going to stick in a needle. Do not bank on the thyroid to decide upon nodule is malignant or benign. So, for example, anyone with a thyroid nodule less than 1 centimeter, you would want it to be thyroid 4, 5, or even 3 to stick in a needle. 1 and 2, you wouldn't do anything. Whereas if it's between, say, 1.5 to 2 centimeters, maybe even for a thyroid 2, you will stick in a needle. So all that you're doing using the ultrasound is predominantly to decide upon whether you're going to stick in a needle and to try and look at the lymph nodes, which you would not have otherwise assessed had you just gone for a thyroid FNA. So this is our own data, which, as you can see here, if you have a thyroid 5, the risk of malignancy is about 86%, whereas if you have a thyroid 3, you have a risk of 20% odd. But at an individual level, you can do nothing in terms of prediction of malignancy. Statistics as a whole for a group might be great, but none of these tests in terms of the thyroids is good enough for decision making at an individual level for a patient. So again, coming back to the FNA and the Bethesda classification, we now know that we are all using Bethesda. I'll just try and, yeah. So we are all using the Bethesda system in classifying the FNA finding, and we are quite happy to know that class 2 is benign, and there you probably would follow up the patient after about 6 months, repeat an ultrasound, plus minus an FNA, and for 5 and 6, when you know that these are probably high risk for malignancies, you are going to subject these patients to near total thyroidectomy. The challenge and the problem that we face is in 3 and 4. 3 is atypia of undetermined significance, or a follicular lesion of undetermined significance. And 4, as you know, is a follicular neoplasm. Now, again, there you realize that between 3 and 4, there are differences in the risk of malignancies. So if you look at Bethesda 3, the risk of malignancy is anywhere between 6 to 30%, whereas Bethesda 4 probably has a higher risk of malignancy. Whereas Bethesda 5 and 6, the chances of malignancy are much, much higher. So whatever form of molecular testing we are talking about, we are talking about in Bethesda 3 and 4. That's where we are going for molecular testing for these indeterminate nodules. And why are we going for those tests? We were talking about the background in terms of what happens in terms of driver mutations. That's the somatic mutations that's there. That is the predominant reason why these people have cancers. But we also know that there are other abnormalities, including chromosomal rearrangements, alteration of gene expression, and microRNA dysregulation. We'll talk about all of that as a little bit. And if you talk about the mutations, most of the studies first started coming up as early as the year 2000, wherein we realized that probably BRAF and the RAS mutation, plus minus the RET PTC and the PAX8 PPAR gamma, accounted for 70% of the driver mutations that we know in differentiated thyroid cancer. Over the next 20 years or so, we have found more and more oncogenic drivers. So in the past, for example, in about 25% of the patients, we didn't know what the driver mutations were. Now that's come down to 3.5%. Now, even 3.5% is a big number. So because even if you looked at all of those mutations in all of the nodules, you would miss malignancy in almost about 3 to 4% of patients, which is quite a big number in terms of missing cancer. So when you're thinking of molecular testing, most of what I'm going to talk is theoretical because it's not available in India. So these are the commercially available kits for molecular testing for thyroid cancer, and I'll talk a little bit about that before we come to our own work. So whenever you're looking at developing a molecular test, first you will have to have a training set of data, then you'll have to have a validation, and then you'll have to have a post-validation. Now at the bottom two columns, if you look at, I've highlighted NPV and PPV, essentially telling us what is the negative predictive value and the positive predictive value. Now, depending upon which test you're using, the negative predictive value and the positive predictive value might help you differently. For example, here, the you have tells us that this test has got a very good positive predictive value. That means if it says that this individual has cancer, then this individual definitely has cancers. Whereas the solid line, as you can see, is the test which has very strong negative predictive value, which is utilized to rule out a possibility of malignancy. So if that test tells us that there is no cancer, then there is definitely no cancer. So all of these molecular testing that we are using in thyroid cancers, in thyroid nodules, the indeterminate nodules, can either be rule out tests or they could be rule in tests, depending upon how good is the negative predictive value or the positive predictive value of the test. And if I kind of put together the test that I mentioned earlier, you can see that, for example, Afirma is a good test because it's got a very high negative predictive value. So if it says, this is not there, it's likely that cancer is not there. Whereas ThyGenX is a test which probably is for a rule out test. And then in the middle, you have few which are relatively balanced. And I'm not going to talk about these because these are still not available in India. But this slide kind of tells us what is utilized in each of those kind of tests or the commercially available tests that we were talking about. So you could do a PCR to detect the driver mutations. You could again go for a next gen sequencing as well for the same, the thyroid genomic classifier. You could look at messenger RNAs and the microRNAs, that is the pharma test. So each of these techniques have been utilized for various commercially available tests. So, for example, the Thyrosec test, it predominantly looks at those 56 driver mutations and is targeted to the DNA and the RNA changes that happen. And this is something which Professor Nikiforov has actually developed. And what is important to understand is for the PAPCA, the BRAF V600E and the TERT give us very good predictive models. Whereas having RAS is probably suggestive of having a follicular thyroid tumor, but RAS can also be present in individuals who have follicular adenomas. So RAS is a bit dodgy because it can be present both in benign as well as in malignant tissues. And the Thyrosec seems to be better in Bethesda 4 than in 3 because I told you Bethesda 4 has a greater risk of having malignancy. So if the Thyrosec tells you, you've got these driver mutations, particularly the BRAF group of mutations, then this is likely to be malignant. So there are other tests looking at microRNA. I'm just skipping through these because if you look at the pharma, again, it's still not available in India. It's a gene expression classifier. It's a microarray test looking at messenger RNAs. Again, here you have an advantage. You can do it in the FNA material itself. You don't need a separate sample to be taken later on. It can be done on the slide itself. So I'm not talking about the ones which are commercially available in the world elsewhere, but what I'm only trying to highlight here is all of those, as you can see, have their own limitations. They're complicated, they're expensive tests, because, for example, the gene sequencer test that's there in the United States, one test would cost anywhere between 1,20,000 Indian rupees to 1,50,000 rupees. And it still has unacceptably high the negative predictive value is quite unacceptable because you're going to miss out a lot of cancers. It's unavailable in India. The other challenge is all of these tests are dependent on the FNA material. Now you've gone and say, for example, operated the thyroid nodule. It's gone and out. Now, how do you can't use these tests anymore in terms of detecting recurrences, and you can't follow up these patients. And neither can you say whether any of these nodules have cancers which have gone and metastasized. So you cannot make any comment from these tests that we've already talked about. So before we jump into our study, I'll talk a little bit about liquid biopsy because that our test is on the basis of liquid biopsy. So for example, when we were sticking in a needle in the thyroid and taking samples and telling what is there in terms of cancer or whether it's benign, it's tissue biopsy. But if you're looking at body fluids, and that can be blood, that can be urine, semen, saliva, anything, CSF, and if you're able to pick up some markers and say whether this individual has a particular disease, here in this case, a malignancy, then that's what is called a liquid biopsy. And through that, you might be able to diagnose whether an individual has cancer. You might be able to say whether it has spread. You might be able to tell us, what's the driver mutation that is present. And then once you've started treatment, you might be able to diagnose whether it has spread or whether it's benign. And then once you've started treatment, you can see is this working or not, and then you can pick up either relapses or even residual tumor cancers. So the classic example of such a liquid biopsy in terms of malignancies that are already commercially available is the COBAS EGFR mutation, and this is currently approved by the FDA for lung cancer. So it's there you can actually diagnose, predict treatment, outcomes, and even detect recurrences. So if you look at liquid biopsy sources, I've already said cell, it could be apoptotic tumor cells. So when we are talking about when a cell is due to whatever reason comes out into the body fluids, and because of cell death, that is apoptosis, or it can even be released from viable cells.
Well, I guess there's something wrong with the connections or some technical problems as I see. Um, well, Dr. Nimi, what do you propose? How we proceed? Maybe we should
Yeah.
continue. Oh,
Sorry,
Dr.
we're
Sujoy is back.
we're back online. Okay,
can
okay.
you tell me where I got disconnected? I'm sorry.
That
As the
figure of the liquid
range of,
biopsy.
Yeah.
sorry.
Can you tell me where to this you have seen, right?
You
The
were
last
showing
one
a
of the
image.
Current FDA approval.
You have got to reshare your screen, Dr. Sujoy, and you were showing the slide with the figure of the liquid biopsy. You know, the figure showing the liquid biopsy.
So just correct me where I am.
The diagram.
Where exactly I got disconnected. So this you would have seen, right?
Yes, yes.
So I stopped, I think, in cell-free DNA. Did you get to hear me talk about cell-free DNA?
Yeah.
Where it comes from?
Yes.
Right. Okay. I'm really sorry for that. My internet is letting me down. So if you look at blood sample, and if you're looking at cell-free DNA, you can look at mutations within cell-free DNA. You can look at the number of copies that have gone wrong. You can look at gene fusion defects there as well as DNA methylation. So if you're taking a blood sample of an individual and if you're looking at cell-free DNA, these are the things that you could have possibly looked at. What has gone wrong in the cell-free DNA? And if you're looking at the clinical application of this cell-free DNA, you could either look at the total quantity of cell-free DNA or those abnormalities of cell-free DNA that I was talking about, which could help us in screening, detection, and early diagnosis of cancer. It could help us in cancer staging and prognosis. It could help us in cancer localization, deciding upon which of the treatments might work, depending on the mutations that you found in it. You could monitor response to therapy. You could monitor drug resistance, and you could pick up residual disease and relapses. So this is our publication looking at plasma cell-free DNA to differentiate malignant from benign thyroid nodules, which is in this month's JCEN. So what essentially we did was we looked at about 150 odd people who came to our clinic with thyroid nodules. Some of them, of course, declined to participate. And we took a blood sample of them. The first one to look at free T4 and TSH. And the second blood sample from that bit, we looked at cell-free DNA. I'll talk about how we looked at cell-free DNA. All of them underwent a thyroid ultrasound and then an US guided FNA and cytopathological classification or Bethesda classification. And we excluded people who had pre-existing malignancies, inflammatory disease, hyperthyroid state, multinodular goiter. And finally, we came up with about 120 odd patients. And if you look at, we've tried to divide this entire study into two bits. On the left-hand side, you can see we've taken people with Bethesda 2 and Bethesda 5 and 6. So people with Bethesda 2 who required surgery underwent surgery, and histopathological diagnosis was taken as gold standard of benign thyroid nodules. And those with Bethesda 5 and 6 underwent surgery, and histopathological diagnosis of malignancy was taken as gold standard for malignancy. So we finally came up with about 58 cases of benign and 11 cases of and 13 cases of malignancy. And if you look at their cell-free DNA levels, pre-surgery, you can see there is a big difference. Somewhere between 29 versus 96. We did an ROC curve. We came 0.992, which is exceedingly good. And we came up with a cutoff of 67. Individual has a cell-free DNA level more than 67.9. We can say with almost 100% sensitivity that this is someone who's got malignancy with 93% specificity. Now, coming to the right-hand side of this particular study, we see that we've got about 37 individuals with indeterminate thyroid nodules. According to current clinical practice in India, all of them underwent surgery, and the biopsy finding was utilized as gold standard whether they were benign or malignant. And we found in the biopsy 13 were benign and 24 were malignant. We looked at their baseline cell-free DNA preoperatively, and we tried to predict, could we have as benign and which one came up as malignant with that cutoff of 67.9. And we could show that we could predict malignancy with 100% sensitivity and almost 92% specificity. So essentially telling us that if you have high amounts of cell-free DNA, you are more likely to have a malignant thyroid nodule. And that's quite logical, because in any patient with malignancy, you expect that there's going to be high cell turnover, more cell death, and excess amount of release of cell-free DNA into the circulation. And this is now proven in other disorders like ovarian carcinoma and breast tumors. Now, cell-free DNA that's increased indeed who had thyroid cancer, they had high cell-free DNA levels, the mean of which was about 86.77. So all of these individuals repeated their cell-free DNA level estimation and found that their cell-free DNA levels had normalized, essentially telling us that the thyroid itself was the source of this increased cell-free DNA level. The other thing that we found very interesting was, we are saying that if it's above 67.9, it's thyroid malignancy. But if you even categorize that thereafter in the groups of people, say, for example, if it's more than 90, if it's more than 110, you can see that the higher it is, the higher likelihood that this is someone who has a higher TNM stage of thyroid cancer. Essentially telling us that the tumor load is more if your cell-free DNA levels are higher, and your malignancy is likely to have spread further if your cell-free DNA levels are higher, which is again quite logical. Next thing that we did was, we had the FNA samples of all of these individuals, and we tried to look at all the driver mutations that are known to try and see whether we could have predicted malignancy in these individuals. And we could find that in 33 out of 37 of these individuals, we had these driver mutations in the FNA samples. So at least in a smaller group, not all, we could have used the conventional next generation sequencing of the FNA material and have predicted malignancy in at least majority of them. What we then did was, we had this cell-free DNA from peripheral blood. We looked at those same driver mutations in the cell-free DNA that we found from the blood. And we could show that these driver mutations were there in that cell-free DNA, telling us that the DNA that's circulating in the peripheral blood is indeed coming from the thyroid, because that DNA has these driver mutations in them. So essentially telling us that clearly this rise in cell-free DNA is because of malignancy, and it's coming from the thyroid, and it has the same genetic signature of malignancy as the driver mutations that you would expect from the thyroid. So what does our study add? So this is the editorial by Eric Alexander, who's a big name in thyroid tumors. And this is what he says. It is with this background that the data by Dutta and colleagues should be viewed with excitement. The authors apply a novel application of molecular testing described in relation to other diseases, its most common application has been to serve as liquid biopsy signature from a tumor through a non-invasive approach. But in this unique study published in the Journal of Clinical Endocrinology and Metabolism, authors performed simple quantitative measurement of total cell-free DNA and analyzed cell-free DNA as a novel diagnostic tool ahead. Though only an initial pilot study, the authors demonstrate the potential for this method to help differentiate benign from malignant thyroid disease. And while a large-scale multi-institutional validation study will be required, the initial discriminatory capacity shown by these data is exciting to ponder. Furthermore, study data demonstrate a significant reduction of cell-free DNA following surgical removal of the thyroid cancer, while also identifying within the cfDNA the common driver mutations known to be responsible for most thyroid cancer. These internal metrics of validity are notable and may lead to further clinical application ahead. Investigations such as this are exciting both for their specific science, but even more so because they support the power of molecularly translating our genomic data into the world of clinical care. Indeed, most predict that physicians and healthcare workers will find their eyes and ears increasingly connected to this field of translational genomics ahead. So we are in the process of replicating the results of our study in a much bigger study, and we are following up all our cancer patients to see whether we are able to detect recurrences early. And one of the things that we have conventionally done in the past in trying to follow up thyroid cancers is looking at thyroglobulin and anti-thyroglobulin. Remember, a lot of our thyroid tumors and thyroid cancers are no longer requiring near total thyroidectomy or followed by radioiodine ablation. So in that case, thyroglobulin is of no use. And again, if a cancer comes back as a dedifferentiated cancer, thyroglobulin might not be increased. So that's again very exciting data. That's my team who have actually helped to do the study. And of course, I thank the Endocrine Society of India as well as the Endocrine Society of Bengal for having funded our study. I shall stop